Okay, great. My name is Marc Ward. I'm from the University of Chicago, and this research was done with Dr. Michael Ujiki from North Shore University Health Systems. Today I'm going to be talking about outcomes in patients with over 1 year follow-up after a peroral endoscopic myotomy or POEM procedure. So the first POEM was done back in 2009 by Inoue, and the idea behind POEM was to do a surgical myotomy with purely the morbidity of an endoscopic procedure. Now, in order to do that, several surgical principles must be in place, and we saw an excellent video earlier today. But we need to establish a mucosal flap. We needed to do an adequate submucosal dissection so that we get an adequate distal myotomy. And we need to be able to secure that closure of the mucosotomy, which has been described by either endoscopic clips or an endoscopic suturing mechanism. The idea behind POEM is to focus on treating only the dysfunctioning mechanics of the lower esophageal sphincter. Now I'm going to get right into some of the data. So what we analyzed is quality of life outcomes in our POEM patients and followed them in a prospective database that was IRB approved. We used a short form 36 questionnaire and did it at different intervals. Here's what we see is a figure at 1 year intervals in which 7 of the 8 domains found in the short form 36 form have been improved at 1 year in our POEM patients. The only one that was not any different was physical functioning, but as you can see, there's actually 2 statistically significant differences in role limitations due to physical health and social functioning. But what about remission? In order to define how good our remission is in POEM, we have to compare it to something. And the current gold standard for comparisons in the treatment of achalasia is the laparoscopic Heller myotomy. So what we did in our prospective database is we analyzed our 24 laparoscopic Heller patients and compared them to our 41 POEM patients. All of these patients had at least 1 year follow-up. And what we found was that the age, the sex, the BMI, the ASA class, the duration of symptoms, the smoking status, and previous or prior interventions were no different between the 2 groups. So since there's no differences preoperative, we wanted to see how they fared postoperatively at 1 year. So what we did is we analyzed all these patients throughout the process, and in the perioperative outcomes, what you can see here is that there's actually 2 statistically significant differences. One is the pain at discharge is actually better in the POEM group compared to the lap Heller group, which is not unsurprising. And the other thing is that the return to activities of daily living is also better, almost twice as good in the POEM group compared to our lap Heller group. Now, although the length of stay between the 2 groups is not different in this study, currently at our institution, we're actually discharging some of our POEM patients on postoperative day 0, so it'll be interesting how this changes over time. In addition, the return to work was also not statistically significant, but what you can see is actually a trend towards the POEM group of those patients getting to work faster. We use Eckert scores to calculate our remission in our patients. Eckert scores use 4 different symptomatic criteria: dysphagia, regurgitation, retrosternal pain, and weight loss. And the degree or the severity of each of these symptoms results in a score of either 0 to 3 for a total scoring analog from 0 to 12. When you have either 0 to 3, then that's considered remission. So we calculate all of these Eckert scores preoperatively and then calculate them at 1 year to find how many of our interventions have been successful. And as you can see here, this is our Eckert scores and the breakdown in our POEM versus lap Heller patients. And if we take a look at the total Eckert score, as outlined in red, you can see that our POEM patients had an average of 6.7 preoperative Eckert score that improved to 0.9, and our lap Heller patients had a preoperative Eckert score of 5.5 that improved to 1. So on average, all of these interventions were successful, and the difference between the 2 groups was not statistically significant. But what caught our eye in this data was that 20 of the 23 patients were successful in the lap Heller group, but that means 3 of the 23 actually failed, which is kind of a lot. And previously there was 24 patients, but we lost 1 to follow-up, so that's not now where there's 23 patients. So we wanted to find out what happened to these lap Heller patients and why they failed. And so what we did is we broke these patients down of all POEM and lap Hellers by the Chicago classification of achalasia. And here's 3 representations of the manometry readings that you see during the Chicago classification. The type 1 is what we think of with classic achalasia. It has absent peristalsis, it has a tight lower esophageal sphincter. Type 2, as you can see in the green, there's a panesophageal pressurization with a tight lower esophageal sphincter. And type 3 is a spastic achalasia, where you can see spastic contractions anywhere along the entire range of the esophagus. And it turns out that all 3 patients who failed our lamellar myotomy were all type 3 achalasia patients. And that's not inconsistent with the data, because the data that we've seen published actually shows that there's about a 30 to 40% failure rate for lamellar myotomies in type 3 achalasia patients. So because of this failure rate, and we wanted to compare POEM to lamellar, we decided to look at just our type 3 achalasia patients. And before I get into the Eckhart scores, I'd like to draw your attention to the average myotomy length. As you can see here, it's statistically different between the 2 groups. The POEM group has an average myotomy length of 19 centimeters, whereas the lamellar group only has an average myotomy length of about 10. Now, the reason that is that from the very beginning, if you approach the myotomy endoscopically, you don't have the anatomic barriers that you would normally have when you approach it laparoscopically. For example, you don't have difficulty in angulation, you don't have increased body habitus that's preventing certain movements. You also don't have the hiatus, which could also get in the way. But with an endoscopic approach, you can start as high as you want, and we even saw in the video earlier that a 20 centimeter myotomy is not an issue with an endoscopic approach. And so knowing that there's spastic contractions anywhere along the esophagus, we decided in our type 3 achalasia patients to perform extended myotomies early on. And as you can see, it looks like it probably had a benefit. What you see here in our type 3 achalasia patients is that the POEM pre-op is about 5.8, and that improved to about 1.1. And the lamellar pre-op was about 5, but improved to about 3, and that led to 5 of 8 patients actually failing, which was this difference in postoperative Eckhart scores was statistically significant despite the low amount of patients, only 9 in the POEM group and about 8 in the lamellar group. Now, what about reflux? When we talk about POEM, we often talk about reflux, and the reason is because unlike a lamellar myotomy, a peroral endoscopic myotomy is not followed by a partial fundoplication. And the thing about reflux is that dysphagia and achalasia and reflux, even though achalasia patients don't have reflux before they have a myotomy, those symptoms of severe reflux and achalasia often correlate. You get regurgitation, you get retrosternal chest pain, you can have dysphagia, and so forth. So as a result, to assess the clinical outcomes, what we did is we looked at our patients preoperatively and postoperatively using different reflux severity indices and standard scoring systems. As you can see here, our POEM patients at maximal follow-up with at least 1 year improved their reflux severity index from 24 all the way down to about 9. We also look at the GERD quality of life, and we saw an increase from 16 all the way down to 6. We also did dysphagia scores, which improved, and this is the dysphagia analog, where actually on a scale of 0 to 5, when you're closer to 5, that's actually meaning less symptoms. So in all 3 of these, all of our patients who had POEM, all 41 of them, on average, had a statistically significant change in their clinical outcomes. And when we look at PPI use, in our series, we saw that the POEM patients had about 47.5% postoperatively compared to about 43.5% in our lamellar group, which wasn't statistically significant between these 2 groups. So in summary, POEM results in statistically significant improvement in achalasia symptoms and quality of life in patients with at least 1 year follow-up. Compared to the laparoscopic hilar myotomy, POEM results in less pain and an early return to activities of daily living. There is no difference between POEM and lamellar myotomy in terms of symptom resolution or PPI use at 1 year. And type 3 achalasia patients may have better outcomes with a POEM and an extended myotomy compared to the laparoscopic hilar myotomy. Thank you very much, and I'll take any questions.